And we're going to be performing for our third and final surgery of the day here at Deuk Spine Institute, a Deuk laser disc repair, which is an endoscopic surgery that was pioneered here at Deuk Spine Institute by myself. And the focus of the surgery is to treat back pain and leg symptoms called radiculopathy. Some common leg symptoms include weakness, numbness, tingling, pain, neurogenic claudication, and sciatica. So our goal with this surgery is to eliminate the back pain this patient's had and to eliminate their leg symptoms. So you can see the MRI. Now the first thing to take notice of is that the lumbar spine of this patient is not normal by any means, and that there are a lot of problems with the discs. As a matter of fact, if you look at this MRI, you can see that virtually every disc here has some damage, except for maybe the L5S1, the bottom one. Here, that is the L5S1 disc right there. Now we're going to be repairing this herniation and this herniation today because the patient's pain is localized here on exam, and those two disc herniations I think are causing the pain. So we're going to get started. We're going to go from the left side because the patient's pain is on the left side. You can take the view off the computer and bring it down here to the operating table. Hi, I'm Dr. Deuk Majan. I'm the surgeon. We're going to get started. I'm going to talk to my patient. My patient is awake at this point. We do these surgeries on the lumbar spine with the patients having sedation, light sedation. The same kind of sedation, for example, you'd have during a colonoscopy. As long as the sedation's done properly, you don't remember anything, and you're asleep for it. Okay, but our patient is not intubated. There's no tube in their mouth. So for the lumbar Deuk laser disc repair, our patients are awake in the beginning. We're going to put them to sleep. So I'm going to talk to him for just a moment. Sir, Dr. Deuk here. You ready? We're going to get started, okay? I just need you to lay still. Can you do that for me? All right. Now listen, I'm going to give you some numbing medicine to make things feel better. But if you have pain, I want you to say, ouch. And then tell me if the pain's in your back or is it down your leg, okay? So say, ouch, back, ouch, leg. Make sense? All right, we'll get started. In a little bit, I'll put you to sleep, but when you wake up, we'll be done, okay? The surgery will take probably about 45 minutes total. Doctor, you ready? Our anesthesiologist is ready. You're going to feel a little stick and burn. That's just numbing medicine going in, okay? That's me pinching your skin. That's the numbing medicine. Don't be alarmed. I apologize. It'll be over in just a minute. I'm just giving you some numbing medicine. I know. So this patient really has a choice to get rid of their back pain. They could have an open back surgery called a decompression infusion with screws and rods, 5 cc's. Excuse me. Or the Deuk laser disc repair. Now whether I do an open decompression infusion at L3445, or I do the Deuk laser disc repair, which we're about to do, this patient's back pain will go away. Excuse me. I think I'm allergic to work. This patient's back pain will go away equally. So the pain at L34 and 45, I believe, will go away basically 100% with this surgery or with an open fusion with screws and rods and cages. And I do both, and I do both very well. Both of them are done outpatient. But why put yourself through all the pain and suffering of major surgery on your spine with screws and rods when you don't need to? So this patient chose instead to have the endoscopic surgery. It's a 7mm incision. And if you're not sure, you can go to Facebook page Spine Surgery Support Group. That is the Deuk Spine Institute's Facebook support group, and there's a video there comparing the Deuk laser disc repair, which we're about to perform, versus fusion. And you can see the difference in the incision, You can see the difference in the recovery. The Deuk laser disc repair procedure that we're doing doesn't have any metal or implants put in the patient. It's natural. It's a cut in the skin, and then we go down through the muscle, not hurting it, but dilating it. And we pop right into the disc from a side approach that doesn't involve taking any bone out. All the other spine surgeries that are done, let's go lateral. All the other spine surgeries done by other spine surgeons are done open, and they're done with removing bone from your spine. The bone they take out is in the back of the spine usually, and they take bone out from the joints, and that's going to weaken and destabilize the joint. All right, so is he okay? All right, so I need to see the AP view again. So in the lateral view, you can see the side of the spine. You can see that the L2-3 bones are fused together, and that the 3-4 and 4-5 discs are collapsed about 70%. I see. I see it now. It's good. That's good. Well, who changed the... So by the way, for those of you who don't know, these surgeries are broadcast live. So if you're watching the surgery right now at 12:13 and 47 seconds Eastern Standard Time on January 21st, you're watching a live stream. So we don't edit any of our surgeries. We want to not edit surgery because we want you to see what really happens. And editing things means you're cutting out parts. And usually when people edit, they cut out the parts they don't want people to see. So we don't edit any of our surgeries, and we haven't edited them ever. You get to see the real deal. So one of the things about real-time surgery is that we have to address real-time problems during real-time surgery. So right now the power went out to our transducer that's sending the image over to the overhead TV screen. And I use that overhead TV screen. Are you comfortable, sir? All right, it's back. It's back. All right, so I just put some more numbing medicine, and we're gonna try this again now that I can see what I'm doing. All right, so we just lost power to the television monitor, sir. Everything's fine, okay? Remember our deal. If you feel pain, you say ouch. Okay, and just say ouch back or ouch leg, and I'll give you more medicine. Shot? All right, so you can see where the needle is. I have like a little fuzz on my nose. Can you wipe it? It's like on the right side. Just wipe your finger along my mask there. Keep going. Yeah, there you go. There's something there, like fuzzy, tickling my face. All right, just wipe to the side. There we go. All right. So, again, this is reality TV. Now, what you can see is the disc at L3-4 and L4-5, and of course, down at the bottom is 5-1. Now, I can tell you right now, looking at this X-ray, he has very short pedicles, and what that means is he has congenital stenosis. Anybody born with short pedicles, and that's something you're born with, by the way, means that you have narrowing of the spine that you're born with, called congenital stenosis. So I'm going to go around the facet and get into the disc through what's called the transforaminal approach. And that's how we start this whole surgery. So now, the thing is, people's facet joints are usually full of arthritis. Do you feel any discomfort there? Yeah, all right. So I'm on track. It's perfect. I just have to finesse my way past. And these are literally a millimeter channel. You see how perfect that is, okay? I make it look easy. It's actually very hard. But I have Luis here as my inspiration. AP. You all right? You like my joking, huh? All right, we're getting there, okay? We're going to take good care of you, don't worry. We're just taking a picture. Now we're going to go from the front to back and make sure that everything looks good front to back. Oh, it's perfect. Perfect. All right, lateral. You can see the scoliosis, by the way. If you look at the spinous process on that X-ray, they're kind of offset, meaning the spine's rotated. particularly at the 3-4. Alrighty, you comfortable? So, you know, as we enter this disc, I want to make sure we're not getting any leg pain. How's your back? Good? All right, we're in. In like Flynn, okay? Anybody know what that means? In like Flynn? It's for the old timers. Errol Flynn. You remember Errol Flynn? All right, we're in like Flynn. You know who Errol Flynn is? Right? All right. So now we make our incision because we're in one disc and we're going to get into the next. 7 millimeter incision. So the whole, you okay? That's weird. We gave him some local. Let me give you a little more local, okay? Just relax. Everything's okay. You're doing great. We have Lido with epi. You feel that? All right. I'll get better in just a second. You're doing great, by the way. Everything's okay. I'm just giving you more numbing medicine. You've lost 1 drop of blood so far for the whole surgery. So, isn't that great? All right. You're doing fine. We're going to be able to put you to sleep in about 5 or 6 minutes, okay? I just need you to be patient with me. So why does the patient need to be awake? Well, we want to make sure we don't damage the nerve or hit the nerve. I already made the incision as we're passing through the foramen. So that's the whole secret. You don't want the patient asleep, otherwise you could hit their nerve root and not know it because they're asleep and they won't tell you. And you can't rely on intraoperative monitoring. It's not reliable. Shot? Okay. So I'm going to head up to the next disc, which is 3-4, just below his fusion. Yeah. You want to take another shot? And Jordan, I think it's the other way, to be honest with you. Now remember, just a little bit. This level has rotation. So that's perfect. So basically the vertebral bodies are sitting on top of each other, but because his disc is collapsed and it's twisted, well, it collapsed and twisted. It didn't collapse straight down, it twisted. So he's got scoliosis as a result of that twisting. We're not here to fix the scoliosis. We don't need to fix the scoliosis. Fixing the scoliosis won't fix his pain. So we're leaving that alone. That takes screws and rods. And we're trying to avoid that kind of surgery here. So we're going to fix his pain here without fixing his scoliosis. Shot? Now how do I know that's possible? Because I've been doing it for years without fixing the scoliosis. Now when you get higher up towards 3-4, you want to move more medially. You want to start more medially. Shot? You don't want to start so lateral. Is that it? No? Okay. I need to aim a little bit more higher, up towards his head. We call that cephalad. Cephalus means head. Shot? Still not happy with that trajectory. You okay? Shot? Huh? All right. He said fine. Shot? You want some popcorn? Yeah. Are you hungry? Yeah. I bet you are. We're going to be done before you even know it. Shot? We're just about where we need to be. Once I get here, where do you feel that? In your back. That's your facet joint. Just, okay. Where do you feel it? All right. Just try to take it easy. I know it's uncomfortable, but almost done. Yeah. Yep. I'm right on his herniation. Shot? I'm right in the foramen. It's perfect. See, why do we buy anything? Why do I buy the most expensive fluoros in the world, the Siemens? Because they're the best fluoros in the world. If you had a GE or some other piece of garbage, then you wouldn't see that beautiful picture that we're seeing. We know exactly where I am with the needle tip, and I can see it clear as day. Now with other fluoros, you don't have that view. Shot? That's why you want the best, so you get the best results. All right, so we are in like. Nice. The patient said Flynn. I love it. All right, are you comfortable? Well, unfortunately, it won't be pressure. I don't think. Okay. We're going to put you to sleep in just a minute. So here is where I actually test those discs. Now, I'm going to talk to my patient for one more time. What is your biggest problem? Is it back pain or leg pain? Back pain. And do you ever get pain down your leg? No. You get numbness in your leg, tingling, weakness? Huh? All right. So he's a... All right. Well, I think we know where your pain's coming from. How bad is that on a scale of 1 to 10? 8.5. That's all? Didn't go up higher? How high? 9? All right. Is that where you typically get your back pain? Huh? Yeah. So concordant, 9/10, L4-5. So people wonder, how do you know, Dr. Deuk, that the disc causes pain? Do I need any more proof than that? I mean, it's called a discogram. I didn't invent it. Huh? Right? We just did a test, and you almost came off the bed because it hurt so bad. And that's your typical back pain, right? Yeah. And maybe it doesn't get to a 9 all the time, but the location and quality of the pain is the same. Are you better now? Yeah. All I need is stop some water. What's that? Just lay still. Don't try to get up. Okay. You're moving around a little more than I want you to. This one is up against the end plate, so I'm not able to, I need to play with it a little bit. So I'm trying to inject the dye, and I'm meeting resistance because the dye doesn't want to leave the tip of the needle, because the tip of the needle is pressed up against the end plate, and I don't want it there. Shot? It might be better right there. Keep rubbing my elbow on that. Are you okay? All right. So we tested 4-5, right? You feel something there? Yeah. I can't get the dye out. Shot? I'm just stuck in your end plate. There must be some grunge in there. But you know what? I know what to do. Let's go with the guide wire. So this is problem solving in real time. There's a little schmutz at the end of this needle probably, and I'm going to pipe clean it out. Shot. There we go. Let's see if I feel the end plate there. See if that works. Sometimes it works, sometimes it doesn't. Nope. There's too much scar tissue in that disc. That is quite interesting. Let's see if I can move it back a little bit. Shot. And I really want this discogram, not just to record the pain response, but because I want to stain the disc with blue dye. I need that blue dye. I don't have to have it, but it helps a lot. Well, I honestly think this disc has so much scar tissue, I can't get the dye out of it. So, not much I can do about it. We don't see that very often. But we can still do your surgery. You are special. All right, sir. Just, we're going to put you to sleep. When you wake up, we'll be done. I want you to count from 1 to 100 out loud. You're doing great. Everything is perfect. Shot. Keep going. You're doing awesome. All right. Needles out. Guide wires in. Again, we're going transforaminal. We're going through a natural hole that is already there in the spine. If every other surgeon in the world is going to cut right here in the middle, They're going to pull the meat off the bone. They're going to drill a hole in the bone to get to the disc. And by the way, they can't fix back pain with that. They can't fix back pain with a laminectomy. You can't fix back pain with a microdiscectomy. You can only fix back pain by stopping the movement at the painful disc. That's a fusion. And sometimes artificial discs can do it. But the Deuk laser disc repair, this surgery right here is designed specifically to cure that back pain, as well as the leg pain. So it's the best of all surgeries because it's the least invasive. There's no fusion, no metal. You're doing great. Keep going, Shot. All right, let me know when I can move forward. I was unable to do the discogram at 3-4. All right, any questions from our audience? You can see the whole surgery will be done through a 7mm incision. Let me know when I can progress. Go now or wait? Yeah? All right. You have a question, Sean?
Yes, one of our viewers on Facebook asks, with some fractures, they pull the bones together to get compression. Would you ever try to pull the vertebrae together if the gap was small enough?
Okay. So I really didn't hear the question. It's something about a fracture and pulling bone together, but I didn't understand the question.
They're basically asking, would you pull the bones together to get compression if you were treating a fracture?
Okay, so if we're treating a fracture, would I try to compress the bones together? The answer is no. The fractures usually happen with the vertebral body. And the vertebral body fractures we treat usually with a kyphoplasty. Stay there. We don't treat it with laser surgery. And then if there's a fracture in the back of the spine, it's called a pars fracture. If I'm trying to fix a pars fracture, I wouldn't do this procedure either. Now, some people have pars fracture and bad back pain, and we're able to do this surgery to treat the back pain, but not to treat the fracture. Shot? So no, there would be no compressing the spine. Shot? I need a new outer glove.
8.5, please.
I need a new inner glove. You have outer and inner? What's the deal? Are you getting another 8.5 or what? Is that an outer or inner? Luis, I need an answer. So you have an inner too, right? Should I take my glove off? All right. So I'm just changing my glove because there's a tiny little hole that occurred, which is extremely rare. For those of you who watch me do surgery all the time, I think I get one hole every 5 years. So, but I was using the mallet and the impactor on the dilator, and my glove got caught between the two pieces of metal as I was hammering, because I had to hold them there so I could direct it properly. Anyway, the glove got pinched and a little tear happened. So we're okay. I just have to change my glove. That's not the right one, the outer glove over there? All right, let's try this again. Patient's fine, I just had to change my glove. So we'll try this again. All right, shot. Is that it right there? So once again, the dilator shot is moving along the guide wire, and once I get it started, shot, yeah, that looks good. I can take the guide wire out because you don't want to over pinch the guide wire by the tip of the dilator. Sometimes they go different directions. Shot. And I can feel a lot of scar tissue in here. Shot. Yeah, definitely. This is a very collapsed disc space. He's not responding, which is good. I'm just trying to think. It's pretty tight. Let's see. This is the one we couldn't do the discogram because the disc space is so scarred up. So the reason people get discogenic pain, they get an annular tear, they get nuclear material stuck in there, they get a herniation, which is the nuclear material sticking out, and then they get inflammation in the annulus. Now if that inflammation goes on for, the longer it goes on, the more scar tissue you're going to get. Inflammation creates scar tissue. Okay, shot? So some patients that we treat, they've had inflammation going on for many, many, many years, and that inflammation causes tremendous amount of scar tissue inside the disc, like this patient at this disc. Go ahead. Which is L3, L3-4. So when you get a lot of inflammation and scar tissue over the years inside a disc, it literally holds the bones together, like squeezes them and holds them. It doesn't allow them to move. And so as I'm going in here, I'm trying to get the bones to separate by placing the tubular retractor and dilator. And yet I'm unable to get the bones to distract. It's called distraction, because they're literally compressed so tightly from the scar tissue. Shot, I don't think that moved. Now, occasionally we are unable to get the dilator out with just this tool, and we have to use a vice grip. Do we have our vice grip ready to go in case I need it?
Yes, I know.
Let's see. Yep. So, let's try again. Oh, that was hard. Shot? Okay, yeah, we're there. Whew! It's my workout for the day. All right. So hopefully our tube won't be crushed. We need to get together, like I said the other day. Okay, I need to know how many we have, and we should probably buy some more before Wolf jacks the price up, right? All right. A lot of our instruments are made in Germany, and although Germany has great quality and well-designed instruments, they do like to charge a lot of money. All right, we're gonna head down. I don't expect there to be much work to do down at this disc because laser, there's a little bit of tear right there. I'm gonna zap, annular tear. Now, whenever we have really collapsed discs like this, a lot of times you won't be able to see as well because there's some blood in the irrigation. And I'll hopefully get a better picture for you, but right now I don't have a great view for you. Now fortunately I've done this a couple of times. Actually, if you want to know the truth, I've done 1200, and the average of, I want to wipe the scope. I think there's a little bit of blood or a little like air bubbles or something on there. I've done 1200 cases, more than 1200 now, and every case I average about 2.5, 2.4 discs per surgery. So I would say easily I've done over 2,000, maybe 2,500 discs. I shouldn't have worn my new shoes today. They're getting a little wet. Now look how collapsed that disc was, but even then it's still, it's very collapsed, but there's still this little bit of herniation right here that's causing all that problem for the patient. And you can see there's virtually no disc left, but the little bit that's left, there's probably only 10% of this normal, when it was normal disc many years ago, probably only 10% of that disc volume is left. And that little 10% happens to be pretty painful. There's a piece of herniation right there. Now remember, we're inside the disc at L3-4. And there's my grabber, my good German grabber. And I'm taking out little pieces of herniation. And again, there's not much to take out. So one thing that those of you who have watched a lot of these surgeries, hopefully you recognize by now, is that every disc is a little different in terms of how much herniation you got to take out. Some, it's a lot. Some, it's very little. In this case, it's very little. Oh, laser? Now, when I go back in, you just pop it on. Thank you. All right. So, remember, this is the disc I couldn't get the discogram material, the blue stuff in, but you can still see I was able to get some in, just not a lot. Now it looks like there's more space in here. I should have been able to get more. But the reality is that when I put the needle in, it was more collapsed. Now it's more open because I put the dilator in the disc space, so it kind of opened it. Now let's hope and pray we can get this tube out. We can. That's good. One time I had the tube stuck. That was a long time ago. Got stuck in the disc space. So I put the dilator back down and I grabbed both of them and pulled them both out with a vice grip. It worked, but the tube was bent and we had to bend it back. If I had just grabbed the tube and pulled it out, I would have destroyed the tube. And who knows, a piece may have broken off. So you actually have to put the dilator back in the tube, then take both out. Just about done on this one. Like I said, not much to remove. And the other thing, for those of you who haven't watched a lot of these surgeries, you'll know that the size of the herniation or tear does not equate to how much pain the patient has. Any grade 3, 4, or 5 tear can cause horrible pain, or it can cause no pain, and everything in between. So we don't treat herniated disc because somebody has one. We treat herniated disc because they have a herniated disc, and that is the cause of their horrible pain they want to get rid of. Okay? All right, just about done here. And again, I apologize for the poor view from the little bit of bleeding we're getting from the end plate. But we're pretty much done with this level here. That's the epidural space. May want to zap just a little bit here. It's a pretty sensitive area for him. Can feel it twitching a little bit. Oh yeah. All right. Let's see. Looking good. That's where all the pain is, just in the back of the annulus here. Right where the annulus meets the posterior longitudinal ligament. Deuk Spine Institute is really the leader in the world in endoscopic spine surgery. We're the only place in the world that you can get cervical, thoracic, and lumbar endoscopic surgery done. If you think the lumbar incision is small at 7 millimeters, done. The cervical and thoracic is 4 millimeters. It's actually half of this size. It's incredible. Very, very tiny. You haven't done one of those. Wait till you see one of those. It's amazing. So this looks like a shake straw. The straw for the cervical and thoracic endoscopic procedure looks like a coffee straw. All right. So we're done with a really collapsed 3-4 disc. Next, we're going to do the 4-5. Got it? Okay. Let's get the fluoro in. Watch your shoulder there. Any questions from our audience, Sean?
None so far.
All right. Does everybody know what a vice grip is? Everybody in the audience? No? Okay. I'll show you. You guys see this? Yeah?
Yes, we can.
All right. Crescent wrench, vice grip. So you put something in there. All right, put your finger in there, Luis. And literally there's a mechanism that allows it to grab on and literally hold it in like a vice. That's why it's called a vice grip. And then you can pull things out. So I only use this on my employees when they really misbehave. It's rare. All right. Are we ready? Yeah? You're ready? Good. All right, so we're going to get the second level done. It's going to be a guide wire down the needle. Once again. Shot. Okie dokie. Let's see, I need you to relax off there. Okay. Good. Shot. Uh-huh. And we're going to, let's just see, shot. And you want to make sure when you come out, you don't take the guide wire out with you, just the needle. The guide wire needs to stay. Otherwise, if the guide wire comes out, do not try to put it back in without using the needle. So you got to start over. Shot, that's it right there? Okay, good. All right. So one incision. You guys see that 7mm incision? And now we're going to start the second disc, which is the, little bone in there from the last, a little scar and bone. Okay, shot. Looking good. Shot. All right, so guide wire has stayed anchored inside the disc space, which is what we want. I don't want it to accidentally advance into the abdomen. So I'm pulling it back just a little. All right, so let's see where we are. The tip of the dilator is at the back of the disc. This is the L45 disc. We're doing 3, 4, 4, 5, right? Now one thing that we haven't talked much about is what happens to these discs when we're done. What we found is that the Deuk laser disc repair surgery actually improves the mobility and movement of the disc. Why is that? Well, you can see that disc we just did, the 3-4, didn't move at all, right? But when you get in there and you start lasering all that scar tissue away, it actually frees up the movement and it allows the disc to move more, the bones to move more. So rather than, fusion, which takes away movement, artificial discs, which they say preserve movement, but that's debatable, the Deuk laser disc repair actually increases movement of all those surgeries. It's the only one that improves movement. Now you're going to have to take my word for that because I haven't published those results. But that's certainly something, if I ever had a neurosurgeon or orthopedic surgeon that wants to come train, that would be one of their research projects for their training year, is to look at movement of discs after surgery and before surgery and compare them. Okie dokie. So we're looking good here. And we're going to advance the dilator into the disc. Shot again. Not as difficult on this one, but still far from normal. So this gentleman has had clearly tons and tons of inflammation going on in his discs, causing pain for years and years. And all that inflammation creates scar tissue, which is really thick and tough, and it holds the bones together and keeps me from getting in there to fix it. So doesn't mean I give up. It just means I have to be a little more aggressive. Shot. All right, good. So you can see the tubular retractor is entering the foramen. Shot. Just want to make sure I'm not pushing the dilator forward as I advance the tube. The McDonald's shake straw. There it is. Shot. It's a beauty. It's a beauty. I think that's good. Does our audience have any questions, Sean?
One of our viewers on YouTube is wondering, did you apply any steroid to the muscles?
Did I apply any steroids to the muscle? The answer is yes. We give a little bit of depomedrol. Is that right? Depomedrol when we're done. And the reason for that is just to reduce some of the inflammation the surgery may cause. So we do apply a little bit topically. All right. All right. Last one. Last patient. We got done early. I may have to slow down, get my money's worth. I'm just kidding. I'm just kidding. I love our anesthesiologist. She's awesome. It's our first time working together this week, and she's like, honestly, I hate to say this, Dr. Santiago, if you're listening, but she's as good as you, maybe. I don't know. Obviously. Huh? Yeah. I thought maybe he had something real special, but now I see you have it too. All right. Having a really good anesthesiologist is very important to do any surgery. And we got lucky. We found a couple of good ones. All right, so a little hazy. That's not Los Angeles smog you're seeing. It may be some stuff on the end of the lens. I want to take it out and just check it. Luis, let me see. Let's see, Luis. I think that's better. Okay, we're going back in. There it is, much better. Okay, look at that herniation just wedged in there, just stuck in the back of the disc. We're going to go in and give it a hand, or I should say a pituitary, and grab it and pull it out. That's one of the bad guys, folks. Herniated nucleus pulposus. Just sitting there in the back of the disc because I shoved that piece back in the disc when I put the dilator in. So it's much safer and easier to get it out when it's inside the disc rather than when it's in the foramen. So this is a great technique. It's very safe and effective. The Deuk laser disc repair. Now, remember, we haven't taken a single bit of bone out of this patient's spine. Had this patient gone elsewhere, they would have had a microdiscectomy or even a fusion, most likely a fusion. And the fusion would be with screws and rods, very painful, very long recovery, unless he had it done here with me, where it's outpatient. It's still painful though. But everywhere else in the world, fusions, say of 2 levels with interbody cage, reconstruction, osteotomies, posterior and interbody fusion with instrumentation, you're going to be in the hospital for at least 3 or 4 or 5 days with blood loss and lots of pain and lots of narcotics. So we're doing this surgery with a 7mm incision, no narcotics after surgery, and no fusion or metal, so no hospitalization. Our surgeries are all done outpatient in our surgery center, free of communicable diseases, which is why we've not had a complication in now 8 years we've been doing these surgeries. 8 years this year. 8 years? Let's see, 14, 21. Sorry, going on 8 years, so it's really 7.5 years. All right, we're inside the disc. Now this is a little different, right? Remember the last disc? There was really nothing in there. So that disc was a little further along in terms of degeneration. This disc is a little more alive, so to speak. So we still have to get rid of the free fragments, the pieces of disc material that are just floating around. We don't want them to pop out later on when the patient gets up and starts walking around. So you want to get those guys out. The rest of this stuff is still functional disc, albeit degenerated, but still functional. And I'm not going to take his whole disc out. My goal here is not to take his disc out. My goal is to leave the disc there. God put it there, I'm leaving it there. My job is to get rid of the part of the disc that's squeezed out through the tear and to clean up the tear so it heals properly without pain. That's what we're here to do. So, and that's that part right there. You all see that? Right in the back of the disc in the foramen. That is the annular tear that hurts. And the nuclear material stuck in there right there. We're zapping it away with a laser. Okay? Don't try this at home. Just because you saw me do one doesn't mean you're ready. You need to be trained if you want to do this stuff. Training takes a year, a full year. Anything less than a year is irresponsible for most doctors. There are some exceptional surgeons that can do it if they've had some prior experience, but sooner than a year. But most doctors plan on spending a year to do it right. Now, there are no training centers in the world to train you on this except for the Deuk Spine Institute. There are a few places that may offer some courses, but the problem is the people that sell these endoscopes, they all want you to think you can be trained in a weekend, but you can't. They're not the ones who get sued when the patient has a complication. You do. The doctor does. So, and the hospital probably does. So don't believe the salespeople. They're always just trying to make sales. You gotta trust your gut. And if your gut tells you you're ready to do these kind of surgeries after a weekend course, then you need to go and have gut surgery done because your gut's wrong. This is not a weekend course type of surgery. You need a gut check, and you need to check your license in back at the Board of Medicine because you're not going to have it for very long. These surgeries look easy and fun. They are fun because I make them fun. I could also make them unpleasant if I wanted to and act like a typical neurosurgeon. Shut up, Luis. Stop doing that. What's wrong with you? Huh? I'm talking to you, Monica. But give me some instruments to throw. The problem is there's just not a lot of instruments we use during the surgery, so there's really not much to throw at people. So my staff keep the instruments away from me. Huh? The sharp ones? So the reality is we're pretty much done. The reality is it is fun when you're actually curing disease, curing pain, and you're doing it in a way that is revolutionary and safe and effective, and patients love it. You become their hero, and it's a wonderful feeling. My whole team and the anesthesiologists, they're all heroes today because we fixed 3 people that will be out of pain for the rest of their life. All right, guys. I think I'm done. Let me take this out. You can see some fat up there at 12 o'clock. We'll see if we can see the nerve. I think that might. It's kind of hard to tell. It looks like it's just connective tissue outside the nerve. That's where the herniation was. It's now gone. We're done. So I expect his back pain to be gone. We'll check on him in recovery. In the meantime, type up your questions. I'm going to show you the incision in just a moment. And then I'm going to leave here. I'm going to come answer your questions, so type them up. And then we're going to go see our last patient, the 2-level laser that we just finished an hour and a half ago. And we're going to send her home. And we'll see how she's doing, okay? Curing back pain, curing neck pain every week. That's what we do here at Deuk Spine. We want to spread the word so everyone learns and knows it can be done safely and effectively. But you have to travel. That's the downside. Until we actually open more Deuk Spine Institutes around the world, which we will do someday. All right, so I'm going to show you the incision. Just to highlight what we did. Remember, we have to hold pressure. We want to avoid intramuscular hematoma. It comes from venous bleeding. All you need is 10 millimeters of mercury pressure, unless, of course, they have high central venous pressures. which we don't expect this patient to. So I'll hold 15 to 20 millimeters of mercury just to be safe. Well, everybody, 3 surgeries done by 1 o'clock. That is excellent. I'm very pleased. You'll all be enrolled in the Jelly of the Month Club. You guys finally I picked a movie that people know about, right? Okay, you guys ready, Sean, to take a look at this thing?
Yep, we can see
There it is. Voila. The whole surgery was done through this little cut. No bone removed from the spine, no laminectomies, no facetectomies, no destructive procedure. Totally natural. The only scar tissue from this whole surgery will be that incision. And you won't even be able to see it in 6 months from now. All right, type up your questions, folks. I'll come answer it, and then we're going to take a look at our last patient. I threw a Ray Tech off the field. disc open laser to repair the disc and basically do an annular debridement, remove the herniation. That way the disc itself will heal. It takes a year to fully heal the disc so it doesn't get re-injured again. But the pain usually goes away immediately. And I'm going to take you over to our recovery room in a little bit, and we're going to go see our patient that we just did laser surgery on. She had a L5-S1 and L4-5 disc herniation on the right side, and she's ready to go home in about 5 minutes. So we're going to shut down this live stream. We're going to head over there, and we're going to send her home. Okay, we'll see if she agrees to being videoed. In the meantime, we did have a question. Do we operate on famous athletes? The answer is yes. We don't discriminate against anyone, right? So whoever wants to come and have surgery done, happy to take care of them. The only issue is that if we have a patient whose weight would restrict our ability to do the surgery, or if they have some kind of a really severe medical problem and they're basically really, really sick and couldn't tolerate the surgery. So those are really the only two types of patients that we wouldn't be able to help with the laser surgery. Everyone else with a herniated disc and pain, we're able to fix. Those patients with weight, they would have to be about 500 pounds or heavier. Once you get to that weight, it's really hard to do the surgery. We don't have the right equipment. The tubes that we use and the instruments we use, well, they're only so long, and they're really not designed for people that are over 500 pounds. So we've had patients up to 400 pounds, maybe even a little over 400 that we've treated effectively and safely. But, you know, we've almost never had to turn anybody away. So patients love the surgery. They do fantastic. We're done for the day. We're going to go check on our patient in recovery. And then this one, of course, that we just finished, we'll check on her as well. Sorry, him as well. Any questions? All right, great. Well, I hope you enjoyed the surgery, and we'll be back next week. What day are we doing surgery next week, Sean?
Tuesday.
I believe Tuesday. So if you're interested in watching more live spine surgery, do we have anything exciting coming up next week, surgery-wise?
PCDF and 1 DLDR.
Oh, posterior cervical. By the way, let me show you what I've got you all here. Let me show you a little bit about the alternative, which I talked about during the surgery, which is spinal fusion, okay? So normally, I got my models here. Normally, this is the lumbar spine. And this part of the spine is called the tailbone or sacrum. The first bone above the sacrum is L5. And then the next one is L4, L3, L2, L1. And then it goes into the thoracic spine. Is it okay? Am I looking good here? All right. So the most common disc herniation to cause back pain, with or without leg symptoms, is the L4-5, this guy right here. And once again, what I was telling you all before is that herniations or tears and herniations that are on the side of the disc, this would be the side, or the front of the disc, this would be the front, they don't cause pain because the nerves that go here, the sensory nerves, they are called visceral afferent nerves, VA, visceral afferents. And they go to parts of the brain that your brain can't really tell when those nerves are activated. They can't tell where the pain's coming from. It doesn't map out anywhere in the body. So your brain doesn't even know when there's a tear and inflammation in this part of the disc. Now, in the back of the disc, back here, there's a special nerve called the sinovertebral nerve. Sinovertebral nerve. How's this? Good? So the sinovertebral nerve literally comes out of the foramen dorsal root ganglion, and it comes back and it innervates right here. So it does all the sensation to the back of the disc. Now, when you get a tear in the annulus here, in the back of the disc, and the jelly is squeezed out a little bit, kind of like right here, I'll show you, okay? Like this guy right here, y'all see that? Sean, how does it look?
Right on center.
Huh? Right in center. So when you have a tear, see the annulus here, holding the jelly, the red jelly in? When you have a tear right there, the jelly squeezes out through that tear. Tears in the back of the disc, and this is kind of in the center. In reality, it's usually to the sides, okay? When you have a tear in the back of the disc and you have the jelly squeeze out, the nerve fibers in this area, from here to here in the back of the disc, side to side, they're called somatic afferent fibers. And they carry nerve signals all the way up the spinal cord to a part of your brain, on the opposite side actually, called the primary sensory cortex, primary somatosensory cortex. And if you understand the anatomy of the brain, then you'll know there's a sulcus that runs right here, all right? And in the front of that sulcus is the primary motor cortex that's responsible for movement on the opposite side of the body. And on the back side of that sulcus is the primary somatosensory cortex. It's part of the parietal lobule. And that part of your brain maps out like a little man with your fingers, your arms, your face, and your trunk, and your legs and feet, including your back and neck. And any impulses to the primary somatosensory cortex from nerves in the back of the disc, it tells the brain exactly where the pain is. And that's why people have chronic back and neck pain. Okay? This is something that has mystified doctors for years and years and years. But we figured it out here at Deuk Spine Institute. That's why annular tears in the back of the disc cause horrible pain that patients can feel. They know exactly where it is. They'll put their finger on the worst spot during the exam because it maps out to the part of the brain that allows you consciousness to know where the pain's coming from. Okay? Now, let's get back to this, this spine, this lumbar spine. I told you the alternative to fixing this patient's pain that we just did would be a fusion. And fusions involve screws and rods, okay, which you can't really appreciate just what's going on here unless I show you this model, okay? So I'm going to replace the spine with the model here. Now, if you look carefully, you'll see there are screws that literally go into the bone and travel all the way to the front of the bone. Now, for those of you who watched my fusion surgeries on the lumbar spine, we just did one, was it last week or the week before? Yeah, last week we did a fusion. You saw me put these screws in, okay? And you put them in, these are called pedicle screws, and then you connect the screws together with rods. Rods and screws connect together, and what that does is it makes the bone so they can't move anymore. They're solidly held together. We call that instrumentation. And then we put cages in, like this cage right there, okay, to recreate curvature of the spine. Now, this fusion surgery would work, if I did it, just as well as the laser surgery. But the incision is huge. The pain from the surgery is massive. The muscles never really fully recover, and people get back pain for months after the surgery, just from the surgery. Not from the hardware, but from the actual surgery. So why put somebody through screws and rods, cages, fusions, big incisions, lots of pain, when you could do endoscopic laser surgery, okay? Where we can just enter through the foramen, okay? The foramen is this hole right here. We enter through the foramen, okay, just like that. And using this tube, I can get inside the herniation. I use a laser to basically burn it away and clean up the annular tear. All done with a 7mm incision. That's the magic of the Deuk laser disc repair. It works great. We've had no complications in 15 years. And you can see there's basically bloodless surgery. And everybody goes home an hour after the surgery. So let's go check on the next patient, the one that we did second today, and see how she's doing.